Hello and welcome. My name is Pauline Swinkels and I welcome you to my presentation today on polycystic ovarian syndrome and insulin resistance. I would like to thank Tracy for inviting me to attend. This is my very first actual presentation. So if I make a few blunders, please be kind. I'm sure you will be. Now let me just share my screen with you. Okay, so today we're talking about polycystic ovarian syndrome and insulin resistance. My disclosures are I have been a registered nurse for 40 years. I'm a certified nutrition network practitioner. I'm also a certified metabolic health practitioner. And I am director of my own business called Low Carb Solutions based in Melbourne, Australia. So polycystic ovarian syndrome is the most common endocrine disorder of women of reproductive age. And it's been determined that it can affect between 6 and 20% of women in this group. It is characterized by irregular or absent menstrual periods, acne, hirsutism, which is excessive and masculine facial and body hair growth. And this is often how the diagnosis is made in this group. It is also often associated with other notable metabolic comorbidities, including weight gain, insulin resistance, and depression and anxiety. So, presenting signs and symptoms, what we most commonly see with women in this group is the absence or irregularity of the menstrual cycle. And also acne. Now, the acne can appear in the chin, on the lower face, but we can also see it on the chest and on the back. Hirsutism is also a common feature. This is abnormal and masculine hair growth that occurs again on the face. It can also appear on the neck, on the chest and on the back, but also on the arms and legs. Women may also have a higher than normal BMI and also have central adiposity. So fat deposits situated around the abdomen. And acanthosis nigricans, which is an abnormal pigmentation pattern, can appear. This is also a sign, common sign we see in insulin resistance. There will also be a history of infertility in women who have been trying to get pregnant. Other signs that we may see are depression and/or anxiety, and in 70% of cases, insulin resistance is present. We also see it more commonly presenting in women of Indigenous background, but also it tends to be more common in Asian, North African, and Caucasian European women. Sleep apnea is also a common thing that we see where there are abnormal pauses in breathing during the sleep, and often patients may already have been diagnosed with type 2 diabetes. Now, diagnosis is usually made on the clinical presentation, but to get a proper clinical diagnosis, we would usually order some blood tests, and these would include looking at the luteinizing hormone and follicle stimulating hormone ratio. So they would normally be opposite to what they should be. We'll see elevated levels of luteinizing hormone and decreased levels of follicle stimulating hormone. We would also look at the sex hormones, including estrogen, progesterone, and testosterone. And we would also look at the adrenal hormones. HbA1c would also be a good test to look for looking for signs of insulin resistance or prediabetes. Fasting glucose and insulin levels would also be very useful to determine if there is insulin resistance, and a liver function test would also be helpful. A pelvic ultrasound may also be ordered to observe for signs of ovarian irregularity. An overabundance of follicles may be seen in the ovaries, which have the appearance of being cysts. This is how the name of polycystic ovarian syndrome has come about. but the follicles are normally there. So this is not necessarily a diagnostic tool. PCOS cysts are usually painless. Now, the pathophysiological mechanisms are very complex and not completely understood, but it is agreed from research so far that there are developmental, environmental, genetic, and epigenetic causes that contribute to PCOS. Let's explore this a little further. Hyperandrogenism, or excessive secretion of the hormones from the adrenal gland and the ovary, are a key factor in the development of the problems associated with PCOS. These hormones not only affect and cause PCOS, but can have a deleterious impact on the homeostasis of many other tissues in the body, including our fat tissue, our liver, muscle, pancreas, and the brain. These hormones are secreted by the adrenal cortex and also the theca cells of the ovary. Now, this is where it starts to get a bit complicated, so see if you can follow me here. There is an elevation in the secretion of insulin from the pancreas, luteinizing hormone from the pituitary gland, and antimalarial hormone from the ovary. This is caused by the hyperandrogenism, which speeds up release of the hypothalamic gonadotropin releasing hormone, and we'll shorten that one to GnRH, from the hypothalamus through the inhibition of sex steroid negative feedback on luteinizing hormone secretion. I told you it was going to be complicated. Increased insulin and antimalarial hormone may contribute to neuroendocrine dysfunction. The antimalarial levels are often elevated in PCOS because of an excess of small antral follicles in the ovary. Insulin may also increase the release of the GnRH and luteinizing hormone, which then goes on to amplify this effect. Now, I shall try and explain that a little bit easier in a little chart for you here. So here we have the pituitary hormone secreting increased levels of luteinizing hormone. This has an effect on the theca cells in the ovary, producing more testosterone. Now, if we have insulin resistance, this causes high blood sugar, which will increase insulin secretion by the pancreas. Now, so we have elevated blood sugar and elevated insulin levels, which are signs of insulin resistance. Now, this will trigger the pancreas to produce insulin, which will have an effect on the liver. The poor old liver then because of this effect of the insulin, cannot produce enough of this sex hormone binding globulin, which its job, it's a protein that binds with testosterone. And because there is not enough of this sex hormone binding globulin, there'll be excess testosterone floating around in the bloodstream, which increases the amount of total free androgens circulating, which increases the effect of the PCOS. Hyperglycemia will affect the liver as well, causing the liver to change some of those excess sugars into fatty acids, which increases fat deposits on the body, which in turn increases insulin resistance. So we get this bit of a vicious cycle thing happening. I hope that explains a little easier. It is very complex. So hirsutism, which is excessive terminal hair growth in a male pattern, is a primary clinical sign of hyperandrogenism. It is reliant on the pilosebaceous unit, or the hair follicle, being sensitive to androgens. Ethnic and genetic variations will influence this development. This hair growth can exhibit as excessive facial and body hair, seen in places where women don't traditionally grow hair, such as on the chin, the cheeks, the chest, and the back, but also excessive hair growth on the arms and legs as well. Male pattern baldness may also develop. Women of Asian descent, generally it only will occur in 28 to 35% of women. Acne, including cystic acne on the face and the back, are very common cutaneous signs of androgen excess. Insulin resistance and hyperinsulinemia is particularly prevalent in women with PCOS, affecting 70% of all cases. This is seen both in lean and obese patients. Insulin enhances the stimulating effect of the luteinizing hormone on the androgen production of the theca cells in the ovary. Theca cells in women with PCOS are more sensitive to the hyperandrogenic effect of insulin as well than those of healthy women. Insulin will also inhibit the release of the sex hormone binding globulin from the liver. This sex hormone binding globulin is the protein that binds with testosterone and facilitates its transport. When this is low, the level of unbound and free testosterone are elevated, thereby increasing the androgenic effect. Hyperinsulinemia also affects the skeletal muscle, increasing insulin resistance. There are many studies that show if a woman has suffered from PCOS and becomes pregnant, her baby will also be affected by the excess of androgens. In normal conditions, the fetus is protected from the androgens by the placental aromatase, which converts these androgens into estrogens. Because a mother with PCOS has dysregulated hormone pathways, placental tissue can't function as efficiently, and the fetus is exposed to abnormal androgen levels during gestation. If the child is a girl, it may predispose her to developing PCOS in her reproductive years. An infant born of low birth weight caused by an intrauterine growth restriction, and this is often due to a placental insufficiency, is statistically more likely to develop PCOS in her reproductive years. Diet and lifestyle factors that can cause or exacerbate metabolic and reproductive abnormalities. A sedentary lifestyle and poor nutritional intake may promote insulin resistance and lead to worsening metabolic dysfunction and hormone dysregulation. Endocrine disruptors may interfere with normal hormone regulation. These are natural and synthetic compounds found in plastic bottles and detergents, toys, cosmetics, pesticides, and metal cans. The most common one being Bisphenol A, or BPA as we commonly know it, which effects have been very extensively explored. It has an estrogen-like effect, and exposure has been associated with the development of insulin resistance, obesity, type 2 diabetes, and hyperandrogenism associated with PCOS. Sorry about that. Research with monozygotic and dizygotic twins has also revealed evidence that PCOS is highly hereditable. Mothers can pass the genome onto their daughters, and it is common among sisters. Weight gain is a common feature of PCOS. Androgen excess has changed the fat distribution and accumulation, causing more intraperitoneal and mesenteric or abdominal fat deposits, thus masculizing the fat distribution in the body and increasing visceral adiposity. This is a considered risk factor for developing metabolic syndrome and in turn contribute to aggravating metabolic abnormalities. Androgen excess also affects and impairs the metabolism of fat, which in turn increases insulin resistance. There are clear associations with PCOS and the development of non-alcoholic fatty liver disease. This is due to the metabolic disturbances such as insulin resistance, obesity, and abnormal fat metabolism. It is documented that women with PCOS and hyperandrogenism are more likely to develop a non-alcoholic fatty liver disease than healthy women. There is also increased risk of developing other conditions because of the PCOS, including prediabetes, type 2 diabetes, gestational diabetes, cholesterol and blood fat abnormalities, cardiovascular disease, which include heart disease, heart attack and stroke. And there is also an increased risk of developing endometrial cancer. Some women may develop PCOS after coming off the contraceptive pill, like Yasmin, Yaz, or Diane. This is usually transient as the body hormone homeostasis becomes regulated again. And this can take a period of usually up to 3 months. Some women may develop PCOS in response to chronic inflammation in the body. This inflammation stimulates the ovary to make too much testosterone. This may present as fatigue, bowel problems, autoimmune disorders, joint pain, and chronic skin conditions like eczema or psoriasis. Some women may develop PCOS because of an overactive adrenal gland producing too much of the hormone DHEAS. Adrenal PCOS is not driven by insulin resistance or inflammation. Instead, it is an epigenetic upregulation of adrenal androgens. This accounts for about 10% of cases. So treatment options will vary, but it generally involves education about the condition and individualized lifestyle intervention to target the symptoms. Because many are obese or overweight, diet and exercise planning are really important to change behaviours, and these strategies should include family members to ensure the best outcomes. This will in turn improve the physical as well as the psychological outcomes, as body image concerns and eating disorders are common amongst this group. In this context, a ketogenic diet should be considered as a drug-free therapy aimed at decreasing weight, improving BMI and insulin sensitivity, as well as improving hormone regulation. A ketogenic diet with carbohydrate restriction to 20 grams or 10% of the total intake for the day, proteins of about 15 to 20% per day, and fats up to 70 to 75% per day have all been shown to give marked improvements and reduction in all the clinical signs and symptoms and a return to normal menstrual cycle. This will cause insulin levels to fall, which in turn affect the secretion of all the other hormones. This will lead to weight loss, improved insulin sensitivity, reduction in androgenic hormone release, and normalization of hormone function, which can be seen on blood test results with normalization of all hormone parameters. As the hormone levels normalize, other external symptoms such as the acne, hirsutism, acanthosis nigricans often resolve within 2 to 3 months. Effective weight management is important as obesity exacerbates metabolic comorbidities, and weight losses of up to 7% have resulted in improving menstrual regularity, ovulation, and testosterone levels. The duration of a low-carb, high-fat diet has still not been determined, but this would vary depending on the patient and the individual degree of insulin resistance. The restoration of a normal menstrual cycle will increase fertility and decrease the need for fertility assistance later in life, which is a common occurrence in women of this group without intervention. Education, counselling, and lifestyle interventions should be culturally sensitive, appropriate, comprehensive, and specific to the individual needs. Early identification of at-risk teens may also prevent a lifetime of medical interventions, which is really important for girls of this group. Medications such as metformin and the oral contraceptive pill have also commonly been used in this group as they help alongside lifestyle modification to improve BMI and menstrual regularity and help with the side effects of the hirsutism and acne. If this is going to be the chosen treatment pathway, it will still be important to educate the patient regarding their insulin resistance to ensure a higher likelihood of remission and greater chance of conceiving naturally should they decide to have children in the future. If a woman is of childbearing age and considering parenthood, the pill may not be a treatment option, so a diet lifestyle changes should seriously be considered as an appropriate intervention. Now, these are some photographs of one of my patients that I thought would be very interesting to show you. So you can see on the left, very, very clear signs of the acanthosis nigricans, but also the acne, the presence of acne on her shoulders and her back, and also the hirsutism, so the excessive hair growth. The photograph on the right was taken after 8 weeks of dietary intervention, where you can see the acanthosis nigricans is completely gone, as is the acne. The hair is still quite abundant. Now, because of the androgen effect on the pilosebaceous unit, this can persist for 3 to 5 months. So it can take a little bit longer before this will actually clear. This is the same patient. You can see the pigmentation in her left axilla before and after 8 weeks. This is the right axilla or armpit. This is on her back. You can see a very nice clearance after the 8 weeks, and on her abdomen. And I'd also like to just point out this photo. You can see on the right the vast improvement in her central adiposity as well. And she's got a lovely waist back again. So in conclusion, there are many complex factors that will influence the development of PCOS during the pubertal years and beyond. Hyperandrogenism is the pivotal factor associated with insulin resistance. An individualized treatment plan based on history, examination, and lab testing will identify those at risk and bring about the most positive outcomes for the patient. Outcomes can be easily monitored by observing reduction in visible signs like the acne, hirsutism, and acanthosis nigricans, and return of menstrual flow in a regular cyclical pattern. Effective weight management is important as obesity exacerbates the metabolic comorbidities, and weight losses of up to 77% have resulted in improved menstrual regularity and testosterone levels. The duration of a low-carb, healthy fat treatment protocol will vary depending on the individual degree of insulin resistance. These are my references that I have used. And I'd like to say thank you. Thank you for joining me today. I hope it wasn't too complex. I know it is very, very confusing when we're talking about all the hormones, but it is quite a complex condition. But I hope this has made things a little clearer and also given you some insight as to how easily choosing a low-carb dietary option can help you with your problems. I hope you enjoy the rest of the conference. Bye for now. Thank you.